Okay, so thank you so much, everyone, for being here, and especially a really special welcome to Dr. Laura Gitlin. And Dr. Laura Gitlin, I just want to say thank you so much for being here on this interview, and welcome via Zoom to the Arizona State OT Conference. We are so excited to have you here.
Well, thank you. I'm so appreciative of this opportunity. I'm sorry I can't be there in person, but I'm out of the country. So this is the next best thing. And
That's right.
I know you'll have a very, very effective and meaningful conference. So you'll tell me all about it.
Absolutely. And also, just as a quick backstory, your work has honestly been a big inspiration for advocating for a track at this conference for dementia care. So this is the first OT conference where we actually have a specific track dedicated to OT work in the field of dementia care. And so just a thank you to you for your research, for your work, for your years of coming to these conversations to really move this work forward. So kind of kicking off this conversation and knowing that the presentation that this is part of is kind of bookending a presentation that's really talking about where do we start on a really practical level and low-hanging fruit in regards to OTs working with the presence of a form of dementia. However, your experience is really unique in that you can also help us look kind of from a very different angle at this. So would you mind just starting us out with, like, what is the story of how you ended up having such a strong focus on dementia, as well as the inclusion of OT in that?
Yeah, sure. Well, first of all, I think it's very inspiring that you do have a special track. And to me, that means that, dementia care is coming of age, if you will, in occupational therapy. I do have to say, before I answer your question directly, that the United States is a little behind in this regard. Other countries do have, not all, but other countries do see the broad, scope of practice of occupational therapists, and they're often the leaders, certainly members of the team in dementia care, where that isn't really true here. So it's not unusual in other countries to have an OT as part of a neurology practice and be fully running some of the case debriefings, as well as leading adult day services and so forth. So the United States has a lot to learn from other countries in terms of the role of OT and their recognition and their view of how others view occupational therapy and dementia care worldwide. Yeah. But just in terms of, very quickly, I'm not going to give you my life story, but I grew up in aging, in the world of aging, and was mentored by a really amazing, dynamic environmental psychologist, Dr. M. Powell Lawton. And he was the founder of many basic constructs that occupational therapists use all the time, like activities of daily living and instrumental activities and instruments around that. But I was mentored under, and it kind of fit my philosophical basis as well, from a person-environment fit. And as I started, doing research in this area and trying to measure the fit between a person and their environment, working with occupational therapists, it was just a natural, because that's the paradigm, and that interaction with occupation, it's just quite a natural. So I come at a basic paradigm that's used in occupational therapy from an entirely different discipline, but then the roads meet. And in terms of dementia care, you may know Dr. Mary Corcoran, who I worked very closely with at Thomas Jefferson University. But I started working with her when I was in that department at Thomas Jefferson University. And we just started to apply these principles of best fit. And we saw that it brought an entirely different lens to understanding people living with this progressive deteriorating condition. And it enabled us to think through ways to make life better by making adjustments to competencies through different kinds of environmental redesign, social and physical. So it started, I've always been very interested in person and environments and making a difference and intervening, always, that from the very beginning of my education. And again, taking a very person-centered care approach and using the person environment competency framework was a very natural fit for me. And therefore I was in the lap of occupational therapists very quickly in my career. And it's been a wonderful journey with occupational therapists.
Well, it's a fun story to hear, because I didn't realize that it really was like philosophies. And then that I'm sure that intervention piece, I can see how that really merged the roads, because your research really has focused on places where the environment gets to be a big part of those interventions. So like the home and the community practices. And we'll say a little bit more about, and we'll also have as part of the Arizona experience at some point, this video also about TAP, and you've been part of a couple different programs specifically that involve occupational therapists and evidence-based approaches to dementia care. And we'll say a little bit about that in another question later. So for the next question, you alluded a little bit to this already. And so you mentioned that the US is a bit behind, unfortunately, when it comes to dementia care, and especially with OT's role inside dementia care. So what do you think OTs in the US could be doing differently in their work, even in the next like 1 to 3 months, in order to be better leaders in the US healthcare system as it pertains to equitable and quality dementia care?
Yeah, that's a really powerful question. It deserves a lot of discussion. I hope you have those discussions at the meeting, because, there's a strategic, you're really asking some strategic as well as tactical type questions. So let me just say, as a way of framing this, that what occupational therapists bring to the dementia care world is several important elements. The approach is that occupational therapists bring is to really understand the relationship of cognition with function. That is the person, how they interact with their environment, right? That is a really critical lens. That immediately brings you into a very person-focused, highly tailored, individualized lens, because then it's always, particularly with this kind of chronicity and progressive change, there's always changes in the person's abilities and their environment too. So how you move along the trajectory of the disease, requires a very person-centered and tailored, personalized approach, from strength-based and always finding the just right fit at all different stages of the disease process. And that's why occupational therapists are uniquely qualified. There's other reasons as well, in terms of activity analysis, environmental analysis, and so forth. But, it's really the strength-based and the lens of cognitive function and the environment. And they remain very novel elements. If you look at the research literature, that occupational therapy theories, frameworks, practices really contribute. So knowing that is very, very important. A lot of times, neurologists, for example, they're in the diagnosis world and they don't do it, they're diagnostic. Yes, that's a good place to begin, but it's like, okay, 20 years, what do we do now for 20 years? And they need to be educated about why they should refer to an occupational therapist who does specialize in dementia care, because it does take a slightly different approach, if you will, in dementia care, perhaps, than an occupational therapist may have been trained in. So I think advocacy is huge. and it has to be done in the context in which a person is practicing.
Yeah.
I think working with your national organization, the American Occupational Therapy Association, in thinking through, developing, and I know that they're thinking about this, practice-based learning communities in dementia care to support the developing and increasing community of occupational therapists in dementia care would be important.
Yeah.
And I think really being schooled in the reimbursement possibilities would be very, very important in whatever practice setting, but in particular, home care, right?
Yeah.
But it's really advocating. I mean, I remember, if you don't mind me just saying this one thing and then I'll stop,
Yeah.
working with the occupational therapist at Johns Hopkins Hospital on a behavioral floor. And what we use the tailored activity program. And one of the things that they learned from there is, I mean, that protocol is a protocol. We don't teach activity analysis. We don't teach occupational therapy, obviously, but what we do is put it together in a very unique, tested way that has tremendous benefits for everybody. And what the occupational therapist learned there is leadership in behavioral health on their unit. And that they could serve as as not only in the delivery of the tailored activity program, but also to lead the case debriefings and to serve in a consultancy capacity to the nursing staff, to the CNA staff, and to families to help them understand, in this particular case, the behavioral manifestations of dementia that were very problematic, and in this case landed people in the hospital. And what they learned is, and what not only the OTs learned but the other staff learned, was their great potential leadership in those units because of their clinical perspective, their clinical know-how, and the frameworks that were being used, the cognitive functional frameworks that could be used. So I think advocacy just is a huge role wherever you are. That takes a lot of energy, but it's a huge role.
And I really appreciate the attention that you've given it, and the recognition that you not surprisingly have for each area's nuanced practices. That there's pragmatic obstacles in each area of practice that are important to consider. And I also love the story that you shared in a specific area of OT practice with Johns Hopkins, where the OTs were supported in implementing it, and then the differences that were noticed. I think I'm also hearing that there is this opening up of a vision for really how OTs can use a skill set to support in maybe different ways. And I love that you've also highlighted the importance of looking at reimbursement, because it is important. And the current system has room for adjustments to hopefully help us be more effective. And I also love that the hearing how you see the view of OT. I think sometimes as OTs, we're so in it and we're so close to it that we sometimes take for granted what's actually happening and kind of how to summarize that. But I love that also there's this opportunity to be able to use the skill set to see both big picture and small picture. And to be able to come together at the table with people.
If I could just add one thing to what you're saying, and as you were talking, I was thinking what could be done immediately, and it does take effort and a lot of thinking, is the elevator speech. Right? You're on the elevator with that CEO, and you have to say what is the added value of why that's he or she CEO should put an occupational therapist, in this case, as the lead behavioral lead on a unit, for example. So really learning developing what we call value proposition for occupational therapy in dementia care, I think is something that needs to be done, can be done. I think that's something that you could do as part of the tract and think about.
Yeah.
And it's about helping, not using OT language. It's about using the language that stakeholders matter to stakeholders. It's helping people live better. It's helping the hospital or the clinic or home health achieve the clinical outcomes they're looking for. So that, you know, really coming up with that kind of statement, not being held back by a very limited, from my opinion, view of where OT fits in rehab or in a particular movement of one body part or whatever. So I think that's a really that's something that can be done, should be done, and is achievable in a short period. You gave me a very short period of time there, 3 months.
And you nailed it. And I have not forgotten when I think I first heard you say that. And I want to also acknowledge, you know, our paths have come to cross recently because of your work with COPE, care of older persons in their environment, which is a program similar to, or kind of married with TAP as well as Skills to Care. And that's how our paths have crossed, is I'm working through a grant funded position with Oakwood Creative Care as the lead OT for COPE. And I just also, yeah, there's something about what you said that it's so simple, and it crossed my mind that it was like, yeah, we should have meetups that is just fleshing out that elevator speech. Because it sounds so simple, and it is, but it also, you know, you opened and you said this takes effort, but worth it. So I appreciate that.
Yeah.
So from my experience, the high value that OT can bring is not just in these graded interventions, but like you've said, it's also in this function-based, and especially this evaluation. However, in mainstream US healthcare systems, there's this time/funding limit that we have that often does limit this more thorough function-based cognitive assessment on top of this already thorough OT assessment that's happening. So I'm curious what words of wisdom you have for casting a vision, maybe for OT in the US, being able to fruitfully integrate these function-based assessments inside this payment and healthcare system. I know they're one and the same, especially perhaps with inspiration from how these other countries are doing this, especially with their assessments.
Yeah, well, I think honestly, there's a lot more work that needs to be done in terms of developing assessments. So in some of the assessments that we have integrated into our interventions, they're not scalable or sustainable. You know, they cost too much money. They work in a pilot or a randomized trial because there's funds for that. So I do think measurement is a big issue, but that's just, it's not just in occupational therapy, but to really get at efficiently and quickly, if you will, but validly, cognitive function, and then, you know, the just right fit person environment, there has to be more measurement development and more effort put towards that. So funding from AOTF, for example, or other funding mechanisms to really advance brief but powerful measures, I think is very, very important. It's actually an area that has been identified in various research summits sponsored by the National Institutes of Health, National Institute on Aging in particular. So I think that could be very helpful, getting back to your question about, you know, how do you do all of this in this very limited payment, you know, world, right? Payment world. I do think there are other opportunities that are opening up with Medicare Advantage plans, and they have supplemental benefits that may afford more opportunity for in-home assessments, seeing people, how they operate, how they perform in their living environments, which could, then be helpful. So I think we have to work on multiple fronts. There isn't a magical answer here. And then I think you and I have spoken before, and I know there are many occupational therapists who have this expertise, and that is really understanding the codes, the ICD codes that are available. I have done a little work with CMS several years ago, and I was always impressed with one of their statements, and that was that a number of their codes, ICD codes, CPT codes, I mean the CPT codes, not the ICD, are underutilized. And there are elements, I think, of the Medicare Advantage supplemental benefits that are underutilized. There's a whole care management benefit now in primary care, and that is not well utilized. And having an occupational therapist in primary care is really another advocacy place. And that is happening in some places, right? I mean, so that is going to be very, very helpful too. And then I'm not answering your question directly, but I think the more research that can show that the lens that the occupational therapist brings and the approaches saves healthcare dollars, and we do have a couple of papers on that, publications on that, but saves healthcare dollars, saves the physician time and the practice time. Really looking at the relationship of what is done by occupational therapists in dementia care to the outcomes that matter most in these kinds of settings would really push the payment systems more, because if there's cost savings, then they're more willing to adapt programs, obviously, that involve occupational therapy practices in dementia care.
And you bring up so many great and points that give me hope. And for OTs who are also in the room, who maybe are at the very, very beginning of even considering applying their OT practice in dementia care, a quick backstory that I want to paint that kind of will paint more of the context of what we're talking about is, so for example, when I was first in my home health Part A practice as an OT, I wasn't actually even regularly screening for cognition. It was actually a research article that kind of turned that light bulb on. That was just like, I'm in an incredible position, not only to be present, to be able to do it, but also the information that I obtained from that could be hugely beneficial for discharge planning, safety in the home, et cetera, et cetera. Well, that was step one, is just putting a screen in my practice. But the next step was, the screen is not an assessment. It's not a diagnosis. And the Allen cognitive level was the first, or like the large leather lacing through ACL was the first tool assessment wise that I came upon through mentors, Mary Platt actually, to more thoroughly assess cognition. However, what I ran into in my practice was that is not a quick test, and often it also needs a second step to it. So each cognitive assessment, if well done and thoroughly done, was its own visit. However, it was like, how do you incorporate that? If it's a second visit, you don't get to write goals for it, or you need to change the plan of care that you wrote in your first visit. So there were all these questions and challenges, because it was like, we know this is effective, but do we just eat the time and have a 2-hour eval? That's exhausting also to the people that we're evaluating. So this is the context of the question that Dr. Gitlin and I are discussing, is how do we bring in not just this general wonderful OT assessment, how do we actually go to the next level of where our communities and our families are hungry and ready for us to go? Like with COPE, I've had the experience of, COPE has 3 phases to it. And the first phase in 2 separate sessions is the assessment by the OT. And there's enough information for 2 very full sessions to collect that information. And so it's in regards to this, our stakeholders, these payment models, which are important because ultimately it's like we can show that we can help here, but how do we do it? And what I'm hearing from you is what tools could we create to do this more efficiently and maybe even sooner inside who knows where. But I think it's a great challenge, and I appreciate you helping to like cast these visions of what's needed next, actually. So perhaps last question for today. It's in regards to these different OT certifications and programs that exist. So in today's presentation, we're discussing ways that OTPs can begin to address the presence of dementia care in their areas of practice. And there's a recognition that there are small ways to address the presence of dementia, such as in offering the cognitive screenings in every evaluation with older persons, or advocating for a diagnosis, if appropriate, to referring providers, or even recommending caregivers to support groups or like memory cafes. But there are also a variety of longer-term solutions in the form of these evidence-based OT certifications and models that exist within dementia care, including these that you've helped develop and study, which is Skills to Care, TAP, or the Tailored Activity Program, and COPE, or Care of Older Persons in Their Environment. So the question is, what do you want OT practitioners to know in regards to planning for the future in obtaining these trainings? And perhaps kind of like a feed off question for this is like, how do you envision these programs playing out in the US healthcare system in the next 10 to 20 years? Like, should we, knowing that each training is separate right now, and maybe someone's like, where do I start, or what do you envision? Like, can you just speak to that in regards to these like amazing trainings that exist?
Yeah, so wonderful, wonderful question. I do think it's worth pausing to reflect that so many years ago, 30 years ago, there was nothing. And now we have all these programs.
Yeah.
So that's exciting. And now we have a new challenge. Like, what's the difference between these programs? And I can't afford to be trained in each of them and so forth. So let me give a very brief perspective on this. First, they all share a common core treatment principles. They're all person-centered. They address what matters most, but in different ways, to the family member, the caregiver, or the person living with dementia. They're very action-oriented. They educate about families about dementia through doing, either whether it's activity or practicing different strategies. So they all share common core treatment principles, but they do look a little different. There is a historical timeline in their development, so they build on each other, and each one tested different elements. And to be honest, we haven't stopped. We're now taking everything we learned and we have translated it for telesupport. And we're also in the process, and when I say we, these are my colleagues from Dr. Pearsall, who many of you will know, an occupational therapist, and a colleague at Brown, Dr. Juckowitz. And we're developing now, we're taking all the clinical reasoning and all of the tailoring, and we're developing a digital platform, for example, that links, that uses clinical algorithms to generate recommendations for families that they can use on demand in their own time. So we're always moving, right? That's our job. We have to keep pushing forward. But I think that one of the things that you and I talked about, and we are going to be developing a very quick easy to read flyer as to when to use what. And there are several other interventions. You didn't mention ACT, and there's another telesupport, Good Life model. There's others. So we can do that for the community and it'll be clear. But Skills to Care is really brief. It's a companion to home care. So if the beneficiary in a Medicare Part A or B context is a person living with dementia, Skills to Care can be an add-on and then reimbursed within that, and it's very brief. So some of the ways you choose these have to do with the context of their delivery, but also possibly the presenting symptoms. So the tailored activity program is very focused on behavioral symptoms, although it impacts function in a positive way, and other kinds of clinical outcomes. It's teaching people, families, how to use activity as a therapeutic modality. So it's very focused on that. COPE is a program that is much more in-depth, has many elements of Skills to Care. It includes also a nurse intervention, a nurse protocol that works with the occupational therapist, but the major thrust is the occupational therapist who works with the caregiver. It allows families that need much more in-depth, hands-on assistance and support to learn about the disease, and importantly, the impact of cognition on function, and then the strategies to manage very big challenges that families, caregivers tend to have throughout the disease process. So each of these are a little different. COPE also has an activity component. And then we have others that are, I'm just going to say COPE Light. And we've taken COPE and made it amenable to anybody's for their delivery, for anyone to deliver within an adult day service setting and so forth. So there is a famous quote by Joe McCannon, who used to head up CMS a long time ago, and he used to argue there has to be, this is a paraphrase, there are many ways to many, and there isn't going to be one approach. Some families will do better with hand-holding and in-home intensive work. Others will do fine with a telehealth approach. Others will need the occupational therapist to, well, we just talked about that, blending a COPE with traditional occupational therapy practices to look at fall risk and transfer issues and things like that. So there, I think we shouldn't be afraid of all these things. It may seem very confusing, and I understand not everyone can be trained in everything, but you know, it's really, these are all part of a toolkit, right? They're all part of your toolkit, and you pull them out and do different things. And of course, we welcome any of these kinds of questions when people have them as to what do you think would be the best program that I should be trained in? And I typically have the discussion, well, you know, who's your, what context are you delivering it in? What's your payment support, and all these different kinds of, and who are you, you know, targeting and so forth. So does that help answer a little bit?
Yeah, and what I'm hearing is really that there's obviously a variety of options out there that are supportive of the use of OT, and also having certain evidence-based certifications. And that if people are ready to pursue that, that really is kind of just a starting point of sharing what their goals or hopes are through going through a training, and really getting feedback first, maybe even before making an investment. See what, or just have that conversation, reach out to kind of shake out each of the programs, and maybe even explore with after that conversation, or as part of that, exploring with their potential employers, even reambusement for trainings, because it is like, it's going to absolutely impact the care that's being brought. And I think the leadership of the OTs who are exposed to it. So I'm really mindful of time, and I know we are about out of it. Is there anything else that I've left out that you want to part with today before we close?
Well, first, just thank you for this opportunity. And I think this area of, dementia care, it's so gratifying, I think, at least because you can have such a huge impact.
Yeah.
And just being there, listening to challenges that families are having, validating their concerns, and making small tweaks to their everyday routines, their engagement with activity, their environment, it just has huge impact. And so it's an area where you can really see huge benefit. And I think it's very gratifying to know that you can really provide a service to families that honestly, if they get a diagnosis, they're totally on their own. They have
Yep.
nowhere to go. They don't know. They keep thinking they're doing something wrong. They don't understand the disease process, and no one has given them any tools to be able to manage all the different kinds of clinical symptoms that come with the journey of dementia.
Yeah, and you've said it so well. And I'll close with this story because as someone I had an experience to apply COPE in 3 cases, and not done yet with either of those in applying COPE, but there was a spouse of one client, and the spouse said, I thought we just had to put up with this, and he said I was willing to, and that being a diagnosis of Alzheimer's dementia. And they're committed to being in the home and not having to relocate if at all possible. But he says, after I found out about your program being COPE, he says, I actually have hope for the first time. And it has been, like you've just really summarized well, it's really helping to translate what it means, kind of like what the not just what the diagnosis means, but how it's presenting and kind of translating it into this experience of daily life and how he can come beside her in different ways. So it's beautiful, and it's one of the most gratifying practices I've experienced in my 12 years. So thank you truly for everything that you're doing. You're always welcome back to our conference.
Thank you.
Donna, and we will also be, for those here, we'll also be sharing the video of TAP.
Great.
We'll include it in the resources. And Dr. Gitlin, thank you again so much.
Thank you, and have a great conference.
Thank you.
Thank you.